Thank you, Ala, for a very interesting topic, actually. And it's a new topic to all of us. Now, the last presentation is with Dr. Nada Hesham. She's going to give us a talk about sequel of post-COVID infection.
Good afternoon. My name is Nada Hesham Azzeddin. I'm a lecturer of radiodiagnosis at Ain Shams University Hospital. Today, our talk will be about sequelae of COVID-19 infection. The acute course of COVID-19 can range from asymptomatic infection to fulminant respiratory failure. The recovery from COVID-19 infection is variable. Although most will make a total recovery, others will experience sequelae long after they recover from the acute infection, with severity of symptoms ranging from mild to debilitating. Severity of the disease is associated with advanced age, male sex, residence in a nursing home, higher CT sensitivity scores, and underlying comorbidities like cardiovascular disease, diabetes, chronic lung disease, and hypertension. The extent of lung involvement in the acute phase of infection is associated with the degree of underlying systemic inflammation, which denotes a worse outcome. So what is the post-acute sequelae of COVID? Patients recovering from COVID-19 can have persistent symptoms and CT abnormalities of variable severity. The most common symptoms reported were loss of taste and smell, fatigue, and shortness of breath. This constellation of symptoms, initially referred to as long COVID, is now called post-acute sequelae of COVID-19. The etiology of lung disease after COVID-19 may be due to prolonged mechanical ventilation, COVID-19 induced acute respiratory distress syndrome, or direct injury from the virus. Predictors of lung disease after COVID-19 include need for intensive care unit admission, mechanical ventilation, higher inflammatory markers, longer hospital stay, and a diagnosis of ARDS. At 3 months after acute infection, a subset of patients will have CT abnormalities that include ground glossing opacity, subpleural bands associated with restricted pulmonary functions. At 6 months after acute infection, some patients have CT changes showing resolution of the ground glossing opacities seen in the early recovery phase, while others show persistence or development of changes suggestive of fibrosis, such as reticulation with or without parenchymal distortion. As we can see here, this is a CT images of a patient showing in images A taken on admission, there was patchy ground glossing opacities and patches of consolidation. On image B, taken 2 months later, there is moderate ground glossing opacities, multifocal linear reticular abnormalities, and mild traction bronchiectasis. Picture C, taken 7 months after the admission, there is near total resolution of the ground glossing opacities. So this patient had near total resolution of the abnormalities. What are the complications of the post-acute sequelae of COVID? The first one is bronchiolitis obliterans. The identification of neoemphysema, cysts, and mosaic attenuation in some patients after COVID-19 infection suggests that the infection may sometimes result in airflow obstruction. As we can see here, this is a patient after COVID-19 infection showing in image A, which is an inspiratory CT phase. A subtle mosaic attenuation is seen here, which is confirmed on the expiratory phase on image B, showing lobular air trapping indicating small airway obstruction. The second complication is fibrosis. Ventilator-induced lung injury is a direct injury to the alveoli that leads to pulmonary interstitial edema, hyaline membrane formation, and alveolar collapse. This is commonly seen in patients with acute respiratory distress syndrome and can directly contribute to the development of pulmonary fibrosis. This is images of another patient after COVID-19 related acute respiratory distress syndrome, showing in image A 2 weeks after admission, diffuse ground glossing appearance and reticular abnormalities, with traction bronchiectasis mainly seen at the right middle lobe. Images B, taken 6 months later, show decrease in the ground glossing but extensive increase in the traction bronchiectasis and architecture distortion. So this patient had fibrosis and the patient remained symptomatic with restricted pulmonary functions. This is an image of another patient after COVID-19 infection, obtained 3 months after the acute infection, showing ground glossing opacity and mild traction bronchiectasis. Third complication is exacerbation of underlying interstitial lung disease. In a small subset of patients, the etiology of lung disease after COVID-19 appears to be an exacerbation of underlying interstitial lung disease. As you can see here, this is a known patient with hypersensitivity pneumonitis. Image A is the baseline CT, showing mild ground-glossing opacities and reticular appearance. Image B, taken 2 months after the infection, shows markedly increase in the reticular abnormality with mild traction bronchiectasis. Image C, taken 2 months later, showed increase in the traction bronchiectasis. So this patient had progressive fibrosis. The last complication is chronic thromboembolism and pulmonary infarcts. Given the evidence of direct invasion of the endothelium by the COVID-19 virus, as well as the associated hypercoagulable state and increased risk of deep venous thrombosis and pulmonary embolism in the acute infection, there is concern that venous thromboembolism may play a role in a subset of patients with post-acute sequelae of COVID. In these images, we see a CT pulmonary angiogram taken after the infection of COVID-19 infection showing a right interlobar pulmonary thrombus. The lung window in image B shows a wedge-shaped focal abnormality typical for pulmonary infarct. CT obtained 3 months later in image C shows that the main thrombus has resolved, but a linear non-obstructive webs is present in the segmental vessels, typical for chronic thromboembolic disease. In summary, a subset of people recovering from COVID-19 will have persistent chest imaging abnormalities. The most common abnormalities are ground-glossing opacity, parenchymal or subpleural bands, reticular formation, evidence of fibrotic changes, and air trapping. The prevalence of CT abnormalities varies depending on the severity of the initial lung involvement and the time interval since infection. Studies suggest that ground glossing can be replaced with fibrotic appearing changes, which may persist in patients with known risk factors. Precise radiological description is important. The term fibrosis should be reserved for those with clear evidence of fibrosis, such as traction bronchiectasis, honeycombing, and architecture distortion. Comparison with the acute phase imaging is important to understand the temporal course of the disease. The long-term outcome of CT changes after COVID-19 and the impact on pulmonary functions and quality of life still needs further research. Thank you.
Thank you, Nada, for a very nice presentation. Thank you to all speakers. I have to say that chest radiology, whether diagnostic or intervention, are not really taking its fair chance in the Egyptian radiology field. And I think we should push more on the training, research, and work on chest diagnostic and therapeutic parts. I think so. And I would like to hear the opinion of Professor Hesham in this, and then we're going to close this session.
Thank you, Dr. Mohammed, and thank you, everyone. Dr. Ahmed, for the invitation. It's a great pleasure to be around with you, and Hisham's staff are all amazing all the time. I totally agree with you, Dr. Mohammed. يعني chest طبعا مش واخد وضعه قوي كchest imaging، واعتقد ان الايرا اللي جايه هيبتدي يبان دوره اكتر، خصوصا مع دخول حاجه زي اللانج كانسر سكريننج بروجرام في مصر، وان شاء الله يمشي كويس. ده هيحط شويه هايلايت كده على الحته بتاعت ان لا بصوا على اللانج، بصوا على الايمجنج، واتكلموا ككلينيشنز مع